Do you have an advance directive? If you don't, you're not alone. Fully 2/3 of all Americans don't have one. That's really not too surprising since most people don't like to talk about death, especially their own. But an advance directive is a very important document which we owe to ourselves and to our loved ones. I'm Grace Trafton of The Better Part. Stay tuned. Our guest, Dr. Karen Molander, is board certified in emergency medicine and is the recipient of several professional awards and honors. Welcome again, Karen.
Thank you, Grace.
First, tell us what exactly is an advance directive?
An advance directive is a legal document that someone will write explaining what their wishes would be if they're not able to communicate those. It typically goes into effect if someone is so ill or incapacitated that they're not able to express their wishes.
Now, why were advance directives created in the first place?
So this was a long history in development. I think that it coupled itself with the incredible advances happening in medicine. And there was a pretty controversial case that happened in 1983. A young woman by the name of Nancy Cruzan suffered in a horrible motor vehicle collision, ended up being ejected from the car and suffocating, but was resuscitated by the paramedics and found to be in a coma, and then later in something called a persistent vegetative state. And the family felt as though there is no way that Nancy would want to have lived that way. But at that time, there was no understanding of honoring a patient's wishes, believe it or not. And so the family had to argue all the way up to the level of the Supreme Court to try and get permission to get her feeding tube removed. And it still was not granted. Then in 1990, the Patient Safety and Determination Act came into play, or Self-Determination Act came into play. And that said that a patient can direct what they want to have happen if they are in a similar situation. So that's when the whole explosion in legal documents occurred, and they vary from state to state.
Now, do these directives ever expire?
So an advance directive doesn't expire, but if you do change your mind and you develop another advance directive or living will, the one with the latest valid date is the one that we usually honor.
Now, since most of us don't really like to think about death, what is a good way to get the conversation started?
You know, I think one of the ways to get the conversation started is to talk about something that's going on in the news, a case of a patient who you thought died with dignity and you want a similar situation. I think in general it's a real downer of a conversation. It's not one that we're going to have at a cocktail party typically, unless it's a bunch of ER doctors. We have a little bit of gallows humor. But I think that the challenge is looking at the literature and figuring out how to have that difficult conversation. Atul Gawande has a wonderful book called Being Mortal, where it goes through how he had those conversations with his father, as his father was diagnosed with end-stage cancer and was going through the dying process. And then a very interesting book is one from a physician's viewpoint who was dying of lung cancer and his own thoughts about the process and how to die with dignity. And that was Paul Kalanithi. He wrote When Breath Becomes Air. He was a neurosurgeon at Stanford. Very, very compelling book. I do think it's important that we have these conversations.
Absolutely important. Now, tell us, what is a living will and what is the healthcare power of attorney?
So a living will was the first document that was developed where someone said, I want to understand what, I want people to know what I want to happen when I die. And it was first developed by an Illinois estate attorney in the late 1960s. And the reason it was called a will was because it's adapted similar to a will that you have where you're trying to give your property away to various individuals. But in this way, it was trying to direct family as to what you wanted to happen to you when you were no longer able to communicate that to them, but you were still alive, and thus the term living will. And then after that, there became the Advance Directive, kind of encompasses living wills. And there's also something called a durable power of attorney for health care.
And what is that exactly?
So a durable power of attorney for health care is when you designate someone as your proxy to make decisions for you about your medical care. So one of the key things in the California Advance Directive, for example, is it contains both those items. So it says who you're designating as your durable power of attorney for health care, but it also includes the living will. And making sure that both of those are on the same page is really important.
Now, what should we consider when we're choosing a proxy?
The most important thing is that they'll honor your wishes and that they know what your wishes are. It is helpful if they are in the medical field, because sometimes as physicians we're not very good at translating terminology into layperson terms to help them understand. So that's helpful. It's not necessary by any means.
Because most of us may
Aren't
not
in
have
the medical field. Yeah.
right, may not know somebody in the medical field. What happens if the proxy is no longer available?
So on a few forms, you can list multiple proxies. So you can list 1, 2, 3 people. They start with number 1, then go to number 2, then go to number 3. But in the state of California, we have a default system where if someone doesn't have their formal wishes designated, they have not designated a healthcare proxy, by default, we have a series of steps that we go through. Yeah. So it's pretty interesting that it's so well designated in the state of California. The first person that's listed is the client's guardian. For example, if the state is taking care of the patient and the family is not involved, they're the ones who are allowed to make the medical decisions.
So they're the number 1.
Right. And then the number 2 person is your spouse. Number 3 is any adult son or daughter. Then number 4 is an adult parent. So the child may have more power to make the medical decision than the parent. So that's kind of interesting in the state of California.
That is.
And then an adult brother or sister. And then after that would be an adult grandchild or relative who appears to know the wants, needs, desires of the patient involved. And then a friend can be listed after that if you can't get a hold of any family member. And then the last person is the conservator of your estate, or guardian of the estate. So they're lowest on the list.
I see. So that's a very specific hierarchy, isn't it? And that's only for the state of California. It might be different in other states.
It might be different in other states, yes.
Now tell me, what is a post and who should have one?
Well, I'll show you just what the document looks like. It's a bright pink document, so it's not likely to be confused with anything else in your household. And typically I tell patients to have it on their refrigerator. Boom. You know, so it's very easy for the paramedics when they show up at your home to see that you have this in place. And it goes through 4 different portions. It's called the Physician's Orders for Life-Sustaining Treatment. And it can actually be filled out by a physician, a nurse practitioner, a physician's assistant, but it needs to be supervised by a physician. A physician needs to sign the order.
I see.
And it's something that's reviewed with the patient. And the first step, it goes through, do you want CPR or do you not want CPR? I want natural death, or I want someone to initiate cardiopulmonary resuscitation. And then the next step, it talks about what type of treatment you would like provided to you. It can be full treatment with the primary goal of resuscitating you at all costs. It could be selective treatment where you're trying to provide some care, for example, IV antibiotics, but you don't want to do burdensome measures. You don't want to be on a ventilator. You're willing to have oxygen provided, but you don't want to be in the intensive care unit. And then the third option is a comfort-focused treatment, where someone may decide, I'm dying of pneumonia, I don't even want antibiotics, can you just make me comfortable? can I have some oxygen? Can I have a little bit of pain medicine? Because this coughing is really painful. And then the next step is artificial nutrition. So people may decide that they want a feeding tube if they were no longer able to swallow, for example, after a bad stroke, or they may decide, I do not want any artificial nutrition, and they can check that box off. And then Section D is the area where the patient signs, so you can fill this out when you are completely competent, or you can have your proxy sign it for you as your condition has worsened. And this can be filled out multiple times. So you may change your desires. For example, if you're a patient with dementia, who you're early in the dementia spectrum, you may want more aggressive care than at the very end stages of dementia when you're losing the ability to swallow.
Now, this actually sounds very similar to an Advance Directive.
It is. The whole purpose of the POLST was to help provide guidance for the paramedics and the emergency medicine physician, because probably the majority of people who have their Advance Directive at home, they have it in their file cabinet under A for Advance Directive. They're not thinking when they're having horrible chest pain that this could be the moment. And oftentimes when we're in the emergency department, our default position has to be, we are going to do everything. You know, so this document's easier for the paramedics to spot and is what we usually follow. If someone has an Advance Directive as well, we hope that both of these are giving us the same message. But typically, we will be as aggressive as we can be until we can find out more from the family or the proxy.
Have you had experiences where it did not give you the same message?
Yes, I have.
And what do you do?
I think the one challenge is that death is inevitable, but it's also irreversible. And so when I've had a situation where a patient may have had this conversation with their physician and said, I absolutely do not want to be resuscitated, but they didn't have that conversation with their family member. And that's sometimes the most difficult thing. And you have to explain to the family, you know, this is a legal document. I do want to honor your wishes, but she is telling us that this is not what she would want.
So if the two documents conflict with each other, which takes precedent?
Well, typically we call an ethics consult, you know, to try and figure out how we can resolve the issue. But I try to honor the patient's wishes. And typically, you know, family members are pretty good about honoring their loved ones' wishes. It helps a lot if they have that conversation because, for example, you know, a patient's daughter might not want her to die because if the patient dies, then the daughter gets kicked out of the house that she's been living in. So sometimes people have ulterior motives. So that's one of the reasons why it's so important to communicate your wants, desires, and needs with as many people as possible and as frequently as possible.
Good idea. Good suggestion. Now, what is palliative care and who can benefit from it?
So palliative care is when care providers are not only focusing on treatment, but they're focusing on the comfort of the patient.
That's so important.
And the key thing is if someone's diagnosed with end-stage cancer, for example, they can initiate palliative care, but also receive chemotherapy. Whereas hospice is when we know that someone is going to die in a very short time period, and treatment like chemotherapy is no longer of any benefit, and the focus becomes the patient's comfort.
Now, some people think of hospice as a place, but that's not true, is it? No,
hospice can be initiated in your own home, in the hospital, in a skilled nursing facility. There are special standalone hospice homes that exist as well, and they are typically staffed by individuals who are well trained in hospice care. They know what happens when the body dies. They can help prepare family and you for your inevitable death, so that you have a better understanding of what to expect, what's reasonable, what's not reasonable.
So just for my clarification, tell me again, how is palliative care different from hospice care?
So palliative care, you can still be undergoing treatment for congestive heart failure, for emphysema, for cancer. We know that eventually congestive heart failure can kill a person, but they might have 6 months to live. They can continue to be on medications for congestive heart failure, but at the point where congestive heart failure becomes end stage, where the person's heart is giving out, that's when they would be transitioned to hospice care, and perhaps all of their cardiac medications would be stopped because they're no longer showing any benefit.
Sometimes there's generalized statements on the Advance Directive that makes it difficult for physicians to carry out a person's wishes. Tell us about a physician's decision-making process under these circumstances.
So I want to go ahead and read what the California Advanced Healthcare Directive says so people can see how challenging it might be. If you have marked choice not to prolong your life, the statement says, I do not want my life to be prolonged if 1, I have an incurable and irreversible condition that will result in my death within a relatively short time. 2, I become unconscious and to a reasonable degree of medical certainty I will not regain consciousness. Or 3, the likely risks and burdens of treatment would outweigh the expected benefits. That's pretty darn wordy. So, and it's difficult to digest that and try and put it into layperson terminology to explain to the patient, you're having a heart attack. The next step is that we are going to have you go to the cardiac cath lab. So trying to explain to them, how aggressive do you want to be? Or, for example, if someone has an enlarged aorta in their abdomen and their aorta is ruptured, we know that they will die without treatment. And seeing if they understand that that could be a possibility. So it's a very challenging conversation to have, and oftentimes in a very time-dependent situation. So trying to explain to the patient and their family members what illness they do have, what their likelihood of recovery from it might be. And oftentimes in the ER, in those first 24 hours that the patient has the illness, we don't know. So we can say, you know, this is the critical time. They are going to the ICU for a reason. They need to be watched closely, and we'll have a better sense of whether they will survive this illness in the next 24 hours or not. You know.
Do all advanced directives have this similar wording? Are there some different than others?
There is a wonderful advance directive that I like because it also talks about comfort and emotional well-being as well. And it also cites different examples that might exist. For example, do you want your healthcare proxy to take you to a different state if the care can be provided in another state? You might feel strongly about that. No, I don't want to leave the state. That healthcare directive that's a little bit more detailed is called the 5 Wishes. And I really recommend it because I think it gives a good understanding of various situations that may happen and what to expect.
So there's more than one advance directive that a person can fill out.
Exactly. And the 5 Wishes Advance Directive is recognized in, I think, 42 states and the state of Washington, D.C. as being sufficient. So you don't have to use, for example, the California Hospital Association's Advance Directive, which is the one that I was reading from. You can use the one called 5 Wishes. That gives you a little bit more leeway, and you can write specific examples. You know, for some people, they may want IV antibiotics, they may want aggressive treatment, but they feel very strongly that they don't want artificial feeding. You have that option.
I see.
Yeah.
Now, something that's often included in an advance directive is resuscitation when our hearts or breathing stops. What exactly happens during a resuscitation?
So during resuscitation, our first focus is stabilizing the airway. That way we're making sure that someone is not going to have emesis from their esophagus go into their breathing tube and cause problems with their lungs. So typically we put a breathing tube down and we protect the airway. We also initiate what we call CPR, where we start doing compressions on the chest. And our goal is to mimic the beating of the heart, but because what we're trying to do is duplicate the heart, trying to create circulation, perfusion throughout the body. Because we know if we do that, there have been patients who've recovered completely from that event. And we know that if we also protect the airway, we can protect them from getting a pneumonia, for example, after the resuscitation. And during the resuscitation, we also try to figure out reasons. Why is this happening? Is this person having a massive stroke? Are they having a heart attack? Could they have a severe infection? Could they have carbon monoxide poisoning? So we have to go through kind of our list of possibilities in our head as we're going through the resuscitation.
Now, we live in a very multicultural society, especially here in the San Francisco Bay Area. So how do other cultures view death and dying?
That I find absolutely fascinating, because I found that it's very individualistic. So even though someone might say that they're Catholic, they might have very individual desires. So I do try to recognize if someone is of a certain faith and what their belief system is. For example, in Buddhism and Hinduism, they believe in reincarnation. So they think that this is just one trip on the world, and they're going to have more and more and more. And there's other people that believe in an afterlife. So certain forms of Judaism, Islam, Christianity. And then there's some people that believe that there's a balance. So Taoism or Confucianism, where it's a yin and a yang. There's death with life, you know. So it's very interesting to see how people's cultural beliefs affect how they respond to even bringing up the word death. How they mourn the person who has died, and what that whole process becomes.
Have you had some challenging experiences related to the cultural differences?
I think that it's a stressful environment regardless. I think when I was very early in my training, we were taught that the word 5 resembles the word death in Mandarin. So we were taught never to put a patient in room number 5, for example.
It's 4.
Oh, it's 4. Oh.
It's number 4.
Yeah, I always forgot. I already forgot. But that's one example where we were taught not to put a patient in a room number 4 because the word resembled the word death in Mandarin.
Right, that's absolutely true. Why is this so important for people of all ages to have an advance directive? Because often people think it's only for the elderly.
I think people don't realize how many people die in car accidents each year.
Right.
You know, and you can have a car accident whether you're 15, 25, 35, 85. And I think it's important for people to realize that death will happen to everybody. And Lord knows, we don't know when it will happen the majority of the time.
Exactly.
You know, so I think it's important to let people know what your wishes are. If it is important for you to be involved in that process, you know.
And how is it determined whether I'm competent to make my own end-of-life decisions?
So I think the key thing that we try to determine is whether you understand what is going on. You know, so we try to ask you, what is your understanding of the situation at hand? What process do you expect to see? What interventions would you like us to follow? And what choice would you like to make? Always giving people a choice. So we have to determine competence every time we have a patient in the emergency department. For example, someone who is coming in with crushing chest pain, they show signs of a heart attack on EKG, they show chemical test results that show evidence of a heart attack, but they want to go home and let their dog out, or whatever the case may be. And in that situation, we have to determine competence. Okay, do you understand what a heart attack is? You know, can you tell me what your understanding of it is? Do you understand what the tests are involved? Do you know what would happen after this point, so that they can make an educated choice about what they want to do? And I've had patients who've still gone home to take care of the dog and then dialed 911 or, you know, whatever the case may be. But I do try to help them solve the situation. Is there anybody I can call for you to take care of the dog? you know. So I try to help problem solve in that realm so that hopefully, or one of the other things I'll say, if you were my family member, I would not recommend that you leave. You know, I would recommend X, Y, or Z treatment.
Sounds like a challenging job that you have.
Yes, it can be.
Now, California has passed the Right to Die law. Can you tell us about this law?
So this law was passed to help people, the term that they use, die with dignity. So it's typically someone who is going to die within the next 6 months from their illness. So they're considered terminal. And they have to make a request on 3 separate occasions. 2 of them have to be orally, so they have to tell the doctor, I want to die. And they also have to have it written as well. And the 2 of the requests have to be at least 15 days apart. So it's pretty detailed how far it has to go. And there's quite a bit of, so some physicians ethically do not feel comfortable with that, whether it is because of their faith or their cultural background or their interpretation of the Hippocratic Oath. They might not feel comfortable with it. But we typically can guide people to physicians that do feel comfortable with it. And they have to be able to be competent throughout this time period. So they cannot lose the ability to make their own decisions. A healthcare by proxy cannot be involved in this. This has to be the patient. And the patient has to be able to swallow the medications. So they cannot be given by IV. They have to be medications by mouth.
Oh, I didn't realize that.
Yeah.
Interesting. Do you have any closing comments for our audience or any resources you would recommend?
So I guess the key thing is to talk about death. Talk about what your wishes would be. I really would recommend, and I'm not getting paid by anyone for this, but the 5 wishes I really like because it does delve into a little bit more of the layperson terminology and give a better understanding of what to expect. You know, so I would highly recommend that. I would recommend Atul Gawande's book, Being Mortal. I also like Paul Kalanithi's book, When Breath Becomes Air, because they are beautiful pieces of work that explain how challenging it is for physicians to be put in that position, let alone a family member who has no understanding of the medical consequences of saying do everything. And that might mean that their family member is in a vegetative state with bed sores, you know, so it's really challenging for a family member to be left with that. So it's a gift to your living family members or loved ones to do this. So I think it's really important.
It is a gift. And thank you so much for enlightening us on this topic.
Thank you for this opportunity. This is great.
My pleasure. My thanks again to Dr. Molander for explaining to us why it's so important to have an advance directive for people of all ages. And remember to also watch us on YouTube and Roku. See you next time. Bye-bye.